Welcome all of you. Welcome to the Unacademy YouTube channel. I'm your pharma educator, Dr. Arpit Agarwal. I hope the audio and the video quality is appropriate. Let me know in the chat box if there is any issue. So, think we are live now. Yes. So today we are going to discuss a very interesting topic in pharmacology, and that is the drugs affecting the immune system. So we'll discuss about the immune drug. Just a minute. And let's try to understand how the drugs affecting the immune system works. So first we'll talk about the immunosuppressant drugs. Immunosuppressants, very interesting topic in pharmacology. Very interesting topic in pharmacology, and I hope this session would make it very clear to all of you. So when we talk about suppressing immunity, we have to talk about lymphocytes, the T lymphocytes and the B lymphocytes, which are the main cells in cell-mediated immunity. So how does this immune system work? How a T cell is activated? So the story would start with the substance. The story would start with the substance that we call as, let's say, interleukin 2. So this substance I'm referring to as interleukin 2. So this is interleukin 2. Now interleukin 2 will act on its receptors. It's a growth factor for T lymphocyte. So let us suppose that this is a T lymphocyte. Let us suppose this is a T lymphocyte. Now on the surface of T lymphocyte, we have the receptors for interleukin 2. On the surface of T lymphocytes, we have the receptors for interleukin 2. Suppose this is the interleukin 2 receptor. This is the receptor for interleukin 2. When interleukin 2 comes and binds to this particular receptor, a signal is given to the immature T cell. This is a immature T cell to proliferate. The immature T cell will start proliferation. And what does proliferation means? It will divide. Division of the cell simply means cell cycle. So the cell will pass from the S stage to mitotic, and in between you will have the G1 and the G2 stage. So cell will go through the phase of cell cycle, cell will divide, and the T cells will proliferate. So interleukin 2 is a growth factor for T cells. It helps in the maturation of T cells, and this is how it acts. Interleukin 2 acts on the interleukin 2 receptor present on the immature T cells, and it helps in proliferation. It sends a signal in the T cells to proliferate. In this signal, which is given when interleukin 2 receptor is stimulated to the nucleus of T cells, there is a kinase or a protein involved, which is known as mammalian target of rapamycin. Mammalian target of rapamycin is an intracellular protein located inside the T cells, which will help in translating the signal of interleukin 2. So now see, how can we block this pathway? It's very simple. First kind of drug that we can give that will help in blocking this pathway is we will give antibodies against interleukin 2 receptor. Give antibodies against interleukin 2 receptor so that interleukin 2 cannot act. I hope it's clear. We will give antibody against interleukin 2 receptor. What are these antibodies known as? Can you name in the chat box what are the antibodies against interleukin 2 receptor? Antibodies against interleukin 2 receptors. Which antibodies come to your mind? Let me know in the chat box which antibodies come to your mind when you talk of interleukin 2 receptor blocker, antibodies against interleukin 2 receptor. Basiliximab. Prabhakar, we will continue with our drug of choice series. The posting is going to come, but right now focus on this. So Prag says basiliximab, daclizumab. That is very correct. We have two drugs, basiliximab and daclizumab. Both these are antibodies against interleukin 2 receptor. Interleukin 2 receptor. So you can block interleukin 2 receptor by giving these antibodies. Action of interleukin 2 will stop. Second, when this receptor is stimulated by interleukin 2, a signal is transcribed or signal is sent to the T cell to proliferate, but a mTOR protein is involved. We can inhibit this particular protein by giving mammalian target of rapamycin, mTOR inhibitors. We can block the intracellular signal. We can block the signaling caused by interleukin 2 by giving mTOR inhibitors. And these drugs, can you name? Prag, Prabhakar, anyone, can you name mTOR inhibitors? mTOR inhibitors, can you name? Yes, mTOR inhibitors. What are the drugs that fall under this category of mammalian target of rapamycin inhibitor? Prabhakar says tacrolimus, everolimus, xanthan, sirolimus. So we have two, sirolimus and everolimus. These are two important drugs which are mTOR inhibitors. Now my question to you, please try to understand. Please try to understand. Yes, Prag and the newer ones, same tacrolimus and all. Is mTOR inhibitor, is the drug which is mTOR inhibitor decreasing interleukin 2 synthesis? Answer is clearly no. mTOR inhibitors do not, this is very important, do not decrease interleukin 2 synthesis. They do not decrease interleukin 2 synthesis, they just block its action. They just block its action by blocking an intracellular signaling molecule mTOR. Finally, in this diagram, if we see a signal is going via interleukin 2, via mTOR for the immature T cell to proliferate. Proliferation, you all know, would involve DNA synthesis. So we can give certain drugs. That will inhibit DNA synthesis and prevent cell from proliferating, and these drugs will be known as anti-metabolites. Anti-metabolites are the drugs that ultimately prevent or block DNA formation. You stop DNA from being formed, DNA formation. And T cells cannot proliferate. If T cells cannot proliferate, the cell immunity can be suppressed. Anti-metabolites. What are the drugs under the anti-metabolite class? Anti-metabolite class, Prabhakar, Prag, SN, Sayanthan. What are the drugs that come to your mind under the anti-metabolite class? Anti-metabolite, very commonly used class. You have discussed this class many times. Methotrexate, yes. Admil, yes. Methotrexate, what else? Think of something else. Immunosuppressant. Methotrexate is one, but methotrexate is mostly used as anti-cancer. What else? Azathioprine, very good, Prag. Azathioprine. So we can think of azathioprine, correct? Azathioprine is good. Methotrexate is there. Azathioprine is there. Methotrexate is there. But tell me, when you start thinking of such drugs, azathioprine and methotrexate, which side effect comes to your mind? Which side effect you are worried while using drugs like azathioprine or methotrexate? Which side effect are you worried when you start using drugs like azathioprine or methotrexate? Liver dysfunction, okay. Bone marrow suppression, Prag, that is correct answer. Bone marrow suppression is a very great issue with any drug that suppresses the DNA synthesis. So what we have done, we have developed a new we have developed a new anti-metabolite that causes less bone marrow suppression, and that anti-metabolite is known by the name mycophenolate mofetil. Mycophenolate mofetil. So mycophenolate mofetil we'll discuss in detail is also an anti-metabolite class of drug, but it causes less bone marrow suppression than azathioprine. Less bone marrow suppression than azathioprine. So how many classes of immunosuppressants can be discussed in one diagram? How many classes can be discussed in this just one diagram? You can look for drugs blocking interleukin 2 receptor. You can look for mTOR inhibitors, and you can look for anti-metabolites. Okay, so we started with interleukin 2. Interleukin 2 is a growth factor for immature T cells. It acts on interleukin 2 receptor that can be blocked by basiliximab, daclizumab. Then the signal which it is giving to immature T cell is using a intercellular protein mTOR that can be inhibited by mTOR inhibitors. And finally, the proliferation of cell can be blocked by anti-metabolites. But the question rises, where is this interleukin 2 coming from? Where is this interleukin 2 coming from? And that is what you have to understand, that interleukin 2 is coming from activated T cells. Interleukin 2 is coming from activated T cell. So let's say this is an activated T cell. What is this? This is an activated T cell, and this is going to secrete this interleukin 2. This interleukin 2 which we have seen here is going to come from this activated T cell. So this T cell is going to synthesize and secrete this interleukin 2. Now interleukin 2 will be synthesized from the interleukin 2 gene. So we have the interleukin 2 gene inside the activated T cell. Let's say this is that gene which is going to ultimately result in interleukin 2 synthesis. Now this gene needs a factor, a transcription factor, and that is known as NFAT. So this gene is promoted, or its transcription is increased by a factor, nuclear factor of activated T cells, NFAT. So NFAT is a transcription factor. It increases the transcription of IL-2 gene. It supports IL-2 gene, and more IL-2 will be formed. But what happens? This NFAT, nuclear factor of activated T cells, NFAT is attached to a phosphate. And as long as it is attached to a phosphate, this is inactive. This remains in inactive state. This is not active. So in order for it to become active, the phosphate needs to go away. Phosphate needs to go away, and then NFAT will become active. So we have a substance that you call as calcineurin. Calcineurin comes into picture. What is calcineurin? Calcineurin is simply a phosphatase. Please try to understand. It is simply a phosphatase. It will break this phosphate. So calcineurin is a phosphatase which will break this phosphate. NFAT will become active. When NFAT becomes active, it transcribes the interleukin 2 gene, and when interleukin 2 gene is transcribed, more interleukin 2 is formed. So how can we block this calcineurin? I hope now it is clear to you which class of drugs am I talking about. Which class of drug are we going to come? I hope you can understand which class of drugs are we going to discuss now. Yes, so we have the most important, the most widely used immunosuppressant drug, which are known as calcineurin. Calcineurin inhibitors. Calcineurin inhibitors, which include drugs like cyclosporin, which include drugs like tacrolimus. Tacrolimus. Now tell me, calcineurin inhibitors, cyclosporin and calcineurin inhibitors, cyclosporin and tacrolimus, are they decreasing? Are these drugs decreasing interleukin 2 synthesis or not? Tell me this. Are these drugs decreasing interleukin 2 synthesis or not? Yes, Prabhakar. Yashwanath, are these drugs going to decrease interleukin 2 synthesis or not? Calcineurin inhibitors. Yes, so that is what you need to remember. That is what you need to remember, that these drugs, calcineurin inhibitors, they decrease interleukin 2 synthesis. They decrease interleukin 2 synthesis. So calcineurin inhibitors is the beginning of this particular diagram. Immunosuppressant. Calcineurin inhibitors, first category of immunosuppressants that you should know. Drugs are cyclosporin. Drugs that are included in this particular section, cyclosporin and tacrolimus. And what do? They decrease interleukin 2 synthesis from activated T cell. If we cannot block this, we come to the second stage where we block the interleukin 2 receptor. Interleukin 2 receptor blocker antibodies like basiliximab and daclizumab. If you cannot do that also, then block the signaling caused by interleukin 2 receptor by blocking the mTOR protein. So mTOR inhibitors come into picture, which include drugs like sirolimus, everolimus. And if you cannot even do that, then block the proliferation of the cell by giving anti-metabolites like azathioprine or mycophenolate mofetil. So these are the main drugs. These are the main categories of drugs that are used in immunosuppression. So if you have understood this diagram, I will tell you now the details about these particular drugs. What you need to remember besides the mechanism. So I hope this is clear. I hope this is clear, the difference in calcineurin inhibitors and difference in mTOR inhibitors. mTOR inhibitors, as you can see, do not decrease interleukin 2 synthesis, while calcineurin inhibitors decrease interleukin 2 synthesis. That is the main difference. So now let's discuss the nitty-gritties of these particular drugs. The first drug that we have to discuss is calcineurin inhibitors. Calcineurin inhibitors, as I told you, decrease interleukin 2 gene transcription, correct? They will decrease interleukin 2 synthesis. Cyclosporin and tacrolimus are the two main drugs. Cyclosporin, tacrolimus. Prabhakar, everolimus will come to. Prabhakar, everolimus is used in stent. We'll come to that. That is when we are discussing the nitty-gritties. So what you have to remember here, cyclosporin, tacrolimus. You see, you have to understand that the main side effect of these drugs, is high nephrotoxicity. Both of these drugs are highly nephrotoxic. Their main damage is on kidney, both of them. But they are not, but these drugs, the advantage is they are not going to cause bone marrow suppression. So bone marrow suppression is not present with these drugs. They do not cause bone marrow suppression, but their main problem is nephric or renal damage, nephrotoxicity. Calcineurin inhibitors, cyclosporin, tacrolimus, decrease interleukin 2 gene transcription and lead to nephrotoxicity. Besides that, you can remember 4H. What are these 4H? These stand for hirsutism. These stands for hyperplasia. What hyperplasia? Hyperplasia of gum. They stand for hypertension, and it also stands for hyperuricemia. 4H. Hirsutism, hyperplasia of gum, hypertension and hyperuricemia. They are more common. They are more common with cyclosporin. While you can remember DNDA. DNDA. D stands for diabetes, that is hyperglycemia. N stands for neurotoxicity. Neurotoxicity. D again is diarrhea, and A is alopecia. D and D. So these problems 4H are more common with cyclosporin, and D and DA are more seen with tacrolimus. So 4H are more seen with cyclosporin, and diabetes, neurotoxicity, diarrhea and alopecia, they are more common with tacrolimus. They are more common with tacrolimus. Both the drugs' main problem is nephrotoxicity for both. Nephrotoxicity occurs with both. Bone marrow suppression is not seen with both. So that is about calcineurin inhibitors. Calcineurin inhibitors. Then you have the mTOR inhibitors. mTOR inhibitors. mTOR inhibitors, as I told you, involves drugs like sirolimus and everolimus. We have also discussed that these drugs block interleukin 2 action. They block interleukin 2 action but do not decrease the synthesis of interleukin 2. That we have already discussed. The main side effect of these drugs, why would we consider these drugs? Please remember, they are not nephrotoxic. So if patient starts developing too much renal damage with cyclosporin, you get rid of cyclosporin and introduce sirolimus or everolimus in the treatment. So that is their advantage over cyclosporin. If patient develops too much nephrotoxicity, you stop cyclosporin, add sirolimus or everolimus. So they are not nephrotoxic, and their main side effect is again bone marrow suppression. Bone marrow suppression. mTOR inhibitors do not decrease interleukin synthesis, block its action, and main problem is bone marrow suppression. Out of this, sirolimus is also used in drug-eluting stents. So after coronary angiography, we put drug-eluting stents, and the drug which is filled in those stents, sirolimus, prevents restenosis. It prevents restenosis of the coronary arteries. So it is used in drug-eluting stents. Sirolimus, everolimus. So these are mTOR inhibitors, not nephrotoxic, do not decrease IL-2 synthesis, and side effect is main bone marrow suppression. Then third, you have the interleukin 2 receptor blockers. Interleukin 2 receptor blocker drugs, which I have told you are two drugs. Two drugs are there. Basiliximab and daclizumab. Basiliximab and daclizumab. These drugs bind to CD125. CD125 part of interleukin 2 receptor. They bind to CD125 of interleukin 2 receptor. It is a part of interleukin 2 receptor. They are directed against this antigen and they block the interleukin 2 receptor. Out of this, basiliximab is used as immunosuppressant in prevention of graft rejection, that we will discuss. While daclizumab is mostly used for multiple sclerosis. It is used for multiple sclerosis. Multiple sclerosis is the use of daclizumab. It is not used for graft rejection. It is used for multiple sclerosis. The last category of drug we have is antimetabolites. And in the antimetabolite, as I told you, the initial drug was azathioprine. Azathioprine was the initial drug. It is going to inhibit the purine synthesis. Purine synthesis inhibitor, azathioprine, and the main problem was bone marrow suppression. Bone marrow suppression was a major problem with azathioprine. Azathioprine. So what we have done, we have developed a new drug which is known as mycophenolate, which is known as mycophenolate mycophenolate moftil. Mycophenolate moftil. Mycophenolate moftil, please remember, is again going to decrease purine synthesis. It is also a anti-metabolite, purine synthesis inhibitor. Its mechanism is pretty different from azathioprine. It inhibits an enzyme known as IMP. IMP, inosine monophosphate. Iosine monophosphate dehydrogenase. IMP dehydrogenase inhibitor, that is the enzyme that it will inhibit, and by inhibiting it will inhibit the purine synthesis, mycophenolate moftil. Now mycophenolate moftil, you have to remember, will cause less bone marrow suppression than azathioprine. That is its advantage, less bone marrow suppression than azathioprine. Its main problem is GI toxicity. It is going to cause GI toxicity, that is nausea, vomiting and diarrhea. Nausea, vomiting and diarrhea. So less bone marrow suppression is seen with mycophenolate. That is why it is more popular today in immunosuppression than azathioprine. Prag says, sir, isn't it CD25? So I think that is CD25 what I have written. Okay. So it is CD25, not 125. Okay, CD25. That was a typo error. Antibodies against CD25 part of the interleukin 2 receptor. So now these are the important immunosuppressant which are acting on T lymphocyte, and the final category is corticosteroid, which we all discuss and frequently used as immunosuppressant. Corticosteroids. Corticosteroids are potent immunosuppressants, and what they cause, they will cause simply apoptosis. They will cause apoptosis in T lymphocytes. T lymphocytes, that is their main mechanism of causing immunosuppression, and they will reduce the coming out of T lymphocytes from lymph nodes. They will reduce egress of lymphocyte from lymph nodes. They will ask the lymphocyte to remain in the lymph nodes, not come in blood. So corticosteroids, you all know dexamethasone, betamethasone. So these are the main category of immunosuppressant. Now what is the use of immunosuppressant? Why do we use this category of drug? So when we talk of immunosuppressant, the main use of this category of drug is to suppress the immunity for prevention of graft rejection. That is mostly after organ transplant. Prevention of graft rejection after organ transplant. That is the main use. So nowadays a triple immunosuppressant combination is being advocated, is used commonly, which consists of a calcineurin inhibitor plus one anti-metabolite plus one steroid, prednisolone or dexamethasone likewise. So this is the combination which is given for most of the organ transplant, post organ transplant, to prevent the rejection of the organ transplant: calcineurin inhibitor, anti-metabolite and steroid. If calcineurin inhibitors cause too much nephrotoxicity, you can replace it with mTOR inhibitors. And that is the main uses of these particular drugs. In antimetabolite, mainly mycophenolate mofetil is used. In calcineurin inhibitors, cyclosporin or tacrolimus can be used. So that is about the important drugs and the important use of immunosuppressants. So you can see the first diagram that we had drawn and try and understand. This is the diagram which shows you the mechanism of calcineurin inhibitors, which will decrease interleukin-2 synthesis. It will show you basiliximab, daclizumab, which will block interleukin-2 receptor. It will show you the actions of mTOR inhibitors, sirolimus, everolimus, and it will show you antimetabolites, the main types of immunosuppressant drugs. Steroids, steroids simply cause apoptosis in lymphocytes. Okay, they are lympholytic, so they will cause apoptosis. So lymphocytes will die, and that will reduce immunity. So steroids have a lympholytic action. That is why, if you remember, in any lymphoma, whether it is Hodgkin's, non-Hodgkin's, you have CHOP, MOP. P stands for prednisolone. So steroids are lympholytic, and that explains their immunosuppressant action. So these are the main categories of immunosuppressant drugs, and this diagram explains how mTOR inhibitors differ from calcineurin inhibitors, although the names are similar, tacrolimus versus sirolimus, everolimus. So please remember, calcineurin inhibitors decrease interleukin-2 synthesis. Their main problem is nephrotoxicity. mTOR inhibitors block interleukin-2 action. They do not affect the synthesis, and their main problem is bone marrow suppression. So they are kind of alternatives to each other. So that is what we had to discuss. Prabhakar, how does diabetes causes decrease in immunity? That is a topic we'll discuss in detail in diabetes. Basically, hyperglycemia can lead to problems in a variety, but diabetes as such does not decrease immunity. It is hyperglycemia which causes the main problem or more chances of infection, because organisms find it easy to grow when there is excess of glucose in blood. So that is what we had in this brief session of immunosuppressant. I hope you are able to now understand what is the difference in cyclosporin, tacrolimus and sirolimus. That is the main advantage, and why mycophenolate mofetil is more popular today than azathioprine as immunosuppressant. So that is what I wanted to discuss with you. Okay, if you have any questions, please feel free to reach out to me on YouTube, on Unacademy, a platform, anywhere, and I'll be more than happy to discuss it with you. Thank you all for joining, and have a wonderful afternoon and excellent year ahead. Thank you.